The first lecture is an introduction that many of you maybe have seen already, and I gave you the PDF file, which is a little bit more extended than the lecture, so that you can prepare yourself and that you have everything in your computer. So you can concentrate yourself really on the message that I will try to bring to you. So it's based, of course, on basic knowledge of the vascular system to understand why we have a vascular system and how can you transfer that knowledge to clinical application. So the daily life situation when a patient is sitting in front of you. So if you start to think about the vascular system, then it is, in fact, a very old sensory system. The oldest system is taste and smell. And then the next, second best, is the vascular system. It's embedded in many places in your functioning, in the brain, and it takes part in many functions, much more than many people might think. It's not only about image stabilization and posture control and spatial orientation, it's a little bit more expanded. But it works in synchrony with many other systems. So it's some kind of core system, and with the help of other systems, it tries to do its job as good as possible. And that also immediately introduces a problem in interpretation. That's why many clinicians think that because of this overlap, redundancy of sensory systems, you can also miss it. So it doesn't make any difference if you have no vascular system, because there are other systems that can do the job as well. And that is not true, of course. It works in silence. So many people are not aware that they have a vascular system. If you go on the street and you ask them, where is your vascular system? Where are your balance organs? They say, what do you mean, my balance organs? Many people don't know that they have a balance organ, which is completely different compared to vision and hearing. You can see that you have eyes, you can see that you have ears. So it is a secret organ working in silence. But you will know what happens if it doesn't work anymore, suddenly stops working. It's like your heart. It's there, but when it stops, you know. Or maybe you don't know anymore. Okay, so we all know, of course, that the labyrinth, so the combination of the hearing organ and the vestibular organ is cited here in the temporal bone. And as a rough discrimination, we can say that the hearing organ is for the high-frequency motions and the vestibular system for the low-frequency motion. Because motion, vibration, is a sound. So it's the same, it's the physical same principle, it's a movement. How does the vestibular system work? It works like a glass of water, filled to the top. Imagine that you have a little child who wants to bring to you a glass of water because you're thirsty. And it fills it a little bit too much. It's on top. And it tries to move with the glass to you without spoiling any water because she knows that you will say, "Ha! What did you do?" So she's very afraid. She walks very carefully with the glass of water. And you know, with any movement that you make, an acceleration or a tilt or whatever, it will move and you will spoil water. So only with a very smooth movement, without acceleration and without tilt, you can avoid any motion of this fluid. That's precisely how your labyrinth works. In fact, you have two of these glasses in your head. And with any tiny movement, the fluid will start to move, or any other heavy mass inside it, and you will feel the motion. So it's a very sensitive motion sensor. Of course, it's a little bit different. It works like a glass of water. It responds to any tilt and movement in the 3D space, only quiet at very, very, very low accelerations. Constant movements. So when you move very slowly and smooth. Now, if you go to one of the first original vestibular organs, the statocyst, which is present in sea cucumbers, jellyfish, and lobsters, lower animals, then you see that that is a spherical structure with hair cells, and here you can see the otoconia. the heavy mass. As soon as it starts to rotate or tilt or move, there will be a small displacement of the hair cells, and the hair cell movement will be detected via mechanoreception into sinuous sensory fibers to be aware of the motion. Well, interesting is that this organ is in fact, like the glass of water, sensitive for any motion. Rotation, by centrifugation, by translation, by tilt. So it does feel any motion like the glass of water, but cannot discriminate between the type of movement. So it's a very rudimentary organ. And the hair cells, in these organs are relative very primitive to the more developed hair cells that you can see in the higher animals. Because in the higher animals, we have hair cells, the mechanoreceptors, that transfer a small deflection of the stereocilia on top into a modulation of the receptor potential and the action potentials in the nerve. And the interesting thing is that this hair cell is an asymmetric sensor. That's a very important feature that we will use also in the head impulse test, for example. It's a very fundamental asymmetry in the system. But it also gives a direction sensitivity. So now the hair cell responds much more for a movement in one or the other direction. So that is an addition to the statokist. So it's one specialization, one development further. Now if you look at the membrane of human beings and vertebrates, you can see that you have the calcium carbonate crystals on top, laying on a gelatinous area. And below that, we have the hair cells with the stereocilia extending in this gelatinous mass. And if you start to shake this system, then of course the heavy mass will move relative to the lower layers. And by that, you get the deflection of the hair cells. And you can see here that the hair cells have different polarization directions in the membrane. So now, suddenly, the hair cells can give information about the direction of the movement of the membrane. So all kinds of specializations in the build-up of these organs. A next step in the development was that suddenly this utricular system, which is arisen from this statokist, is developed as a two-dimensional structure. So you have the utriculus in the horizontal plane, and you have the succulus in the vertical plane. So now we have a real three-dimensional structure that can make already a difference between the direction of movements. That's the next step in the development in more precision and trying to unravel the secret of the type of motion. So inside these membranes, now the hair cells have a very specific orientation. And they have a different frequency sensitivity. So for slower and faster movements and for directions, now suddenly the membrane can differentiate to the type of direction and the type of movement. So that is for the utriculus. You see an opposite orientation of the direction preponderance of the hair cells compared to the succulus. So now you have a much more complicated membrane. Now add to that now the very principle physics fundamentals that, a change of acceleration in terms of translations is similar to gravity, to inclinations. Give you here the example. If you move from standing still forward, then the heavy mass will lag behind and the hair cells will deflect backwards, indicating an acceleration forward. If you reach constant velocity, the elasticity of the membrane will bring the hair cells back to the neutral situation, and you don't feel a difference between constant velocity and standing still. So again, like the glass of water, when you move with a slow, constant velocity, there will be no displacement. Like in the train, when you move with a constant speed, you don't feel it with your labyrinths, but you can see it with your eyes. And then you stop, and the heavy mass wants to continue to move forward. And then after that, go back by elasticity of the membrane. Now if you tilt your head, if I put my head backwards, it has the same effect as accelerating forwards. So the brain cannot tell you from this deflection pattern whether you are tilting or translating. So this is a very fundamental puzzle that has to be solved in the brain by information from different organs. So one of the next steps, of course, in the development of these membranes is to go for other structures. Here you can see that if you look at the frequency dependence of the utricular system, it's perfectly sensitive for gravity. So if you're tilted, that remains deflected. So there's constant change of information, and when I tilt in another direction, you will feel that. It's a very low frequency sensitivity. But when you move too fast, the relatively bumpy, heavy membrane cannot move anymore. So it will not follow the movements anymore, and you don't feel that. So there is a maximum, like with the audiometry, that you have a maximum sensitivity for different frequencies. And that is the same for the utricular system. And one of the important things is that you realize is that simple changes in the mechanics of this membrane can change this frequency dependence. So if the membrane becomes more stiff by dehydration or things like that, it can change this frequency dependence. And with aging, you can imagine that the tissue composition and the tissue elasticity will change. Now, out of this autokist, the utriculus was developed, so be careful, there is something here. Falling in the elderly, it's dangerous. Succulus. So, and now we split up in the development towards the cochlea, where there comes an organ specialized in the higher frequencies. And we have a specialization and development of the semicircular canals. Now suddenly we develop semicircular canals that have a unique and isolated sensitivity for rotations. Because of that, because of the addition of organs that only feel rotations, now the brain can much more easily solve the problem what kind of movement we feel. Is it translation, or is it a tilt where you have a small rotation, or is it a real rotation? So the development of these canals was very important. And you can see that it's composed, as you always know, of a membranous circular structure, semicircular, and then inside you can see the example that if you start to rotate, the endolymph will make the cupula start to move, deflect. And you can see that the hair cells here in the cupula have a specific direction preponderance. So they all have an orientation in the same direction, and according to the second law of Ewald, that means that a canal becomes direction sensitive. It's much more sensitive for rotation in one direction than in the opposite direction. I try to visualize that by these arrows, that if you rotate in this direction, there's much more response change than if you move in the opposite direction. So each canal has a direction preponderance, and that is a very important issue. A normal canal only sends angular rotations. That is the additional value of the canals. And that is important. And we know examples where it can change. Normally, the canal is also not sensitive for gravity, because the specific mass in the endolymphatic fluid is the same as the cupula. So if you change the orientation, there will be no deflection of the cupula. You don't feel with your canals a constant change relative to gravity, only the change of the movement. Sometimes this changes, and we know all the examples. When you drink alcohol, the alcohol comes into the cupula, makes the cupula lighter, and by that it starts to become sensitive for gravity. And with the BPV, that there's otoliths, canaloliths in the endolymph or attached to the cupula, whatever, but it changes this delicate balance between the specific mass and of the endolymph and the cupula. And by that, the canal loses its specific sensitivity for O rotation only, and the brain gets confused. Not only getting BPPV, but the total system doesn't work properly anymore. So canals sense rotations, and rotations accelerations, no constant rotations, and no gravity. That's a very important key factor.
Dan gaat hij, blijft.
Maybe, can you switch off the sound for a moment?
Dan gaat hij.
So here you can see that for the lower frequencies, there is a slower increase in sensitivity, slow movement, no cupola movement, faster movement, more and more deflection. You see there's an increase in the sensitivity, but there must be a maximum. But at a certain moment, the cupola will not be able to follow the movement anymore, and you will see a decrease, as you can see in the simulation here. So there's no relative movement of the cupola anymore relative to the canal. So you see a perfect optimization in the middle frequency from 0.1 to 10 Hertz. And we have different tests that are related to the frequency response of these canals. We have the caloric test, we have rotary chair test, and we have the head impulse test. But in the natural frequencies, the head impulse test is much more representing, you know, the functioning of the vestibular system. So when you look around, where are you? That is where you use your vestibular system for, not for the very slow movements. In fact, is that precisely what people do when they have a bad labyrinth? They try to avoid the fast movements, the stimulation of the canals, and they live with slow movements. Okay, now every canal has an optimal sensitivity according to the law of Ewald. When you rotate around an axis that is orthogonal to the plane of the canal, so if you want to feel rotations in 3 dimensions, you need 3 canals for each dimension. And this is the orientation of the canals, as you can see here. So the horizontal canal a little bit tilted upwards, and if I rotate to the left, then there is a huge increase in activity there, and the spontaneous activity on the right side is slightly decreased. And so the brain knows that I rotate to the left side, and the other way around. But you see the asymmetry, but because I have 2 mirror-wise organized labyrinths, the total system is symmetric again. That is not strange. That is for many of our sensory systems. Give you an example. For the eye, it's the same. You see much wider and further with your left eye on the left side than with your right eye, and the other way around. So they are complementary, and there is an area where you have an overlap for the binocularity. With hearing, the same. Of course, you hear sounds much better on the right side with your right ear, your left ear with left ear. So that is the same for the labyrinths. You have a asymmetry in the system, and if you lose one labyrinth, you get asymmetry. If you lose one ear, you get asymmetry. If you lose one eye, you get asymmetry. So if you put now all the systems together, how the brain uses this fundamental information from the labyrinths to find out how you move and where gravity is, to control image stabilization and posture control and orientation. You can see that the sensitivity, as you can see here, is for the statolith system and here for the canals. But for these lower frequencies, you know, the canals are not sensitive. So they cannot tell the brain whether something is a rotation or not. And that's why you depend in this lower frequency on vision to see the rotation. So you get the help of the other sensory systems to make the picture complete. It also means that there is some kind of crossover frequency where, you know, the canals take it over from, there's an image stabilization problem with the slide projector, as you can see. But you see that there is a crossover frequency where the canals take over from the other sensory systems, And that is precisely where the brain finds it extremely difficult to solve that problem. And that is the frequency where motion sickness is most occurrent and present. So when you are on a ship and the boat starts to move with a frequency of 0.2 hertz or something like that, the brain finds it very difficult to know whether this is tilt or translation or rotation. And you easily get sick. So there's a predominance. Okay, so that's how the system works. And you can imagine that if you lose canal function, and that is an important clinical issue, if you lose canal function, you use the sensitivity for rotation. But you still feel the rotation with your ventricular system. The only thing is that you don't know whether this is really rotation or whether it is translation or tilt, because you get also signals from that type of stimulus. So the clinical implication of that is that if you lose canals, which you might see with head impulse test and caloric function, you do not have a complete picture. Because the otolith system, the most fundamental, original sensory system, might still be able to feel any motion. Maybe that explains that, well, the impact of losing canals is to some extent limited, because you still have the second hand, not so specific, vestibular system as the ventriculus and succulus. Okay, so we have these two mirror-organized systems, the canals, that are able to detect any motion. And we have the two labyrinths with a very fundamental asymmetry based on the hair cell asymmetry inside the organs. So our labyrinths, to conclude, are very sensitive motion and gravity sensors. Do we really need those labyrinths? That is anticipating on the question whether you have so much overlap with the other sensory systems. Do we really need them? What happens if you lose your labyrinths? Is that something that is really bothersome, or can we just get rid of them? Well, in case of vestibular pathology, for example, a neuritis, we all know that the initial symptoms are vertigo, nausea, and nystagmus. And that is something that we recognize from the history of patients. There's typical, acute loss of peripheral vestibular function. And then the classical picture was that central compensation took over, because what you see is that the symptoms decay in time, naturally, by itself, and you look at the patient and the nystagmus disappears, stability is quite well restored, and the patient starts to complain less. So from outside, everything looks quite normal again. But if you then say, as a doctor, well, don't worry, the other labyrinth takes over, you're lying, because it's not true. Imagine that you are losing the eye on one eye, your left eye, you go to the ophthalmologist, and he says, don't worry, you still have the other eye. The eye takes over on the other side. You will know that's not true. And with hearing, the same. If you go to the ENT, you lose one ear, and he would say, don't worry, you still have the other ear. It's nice, but you know that you will have problems under certain circumstances. And the same is for the labyrinth. So the key question is, but what happens then if you lose one labyrinth? What is the burden? Because from outside, everything looks quite okay. So it seems as if there is a complete recovery in a few weeks to months. So in the acute situation, we have these classical symptoms. But we also know that people can lose slowly vestibular function, like in a vestibular neuroma, schwannoma. Then you have no classical history of vertigo or nausea and vomiting, and even no nystagmus. So you can lose the function without the classical symptoms. That is already worrying if you take the history, and there's no history of the classical symptoms, and you can lose function. It's frightening. Maybe you overlook some patients that have a complete loss of vestibular function. Okay, what happens in an acute bilateral loss? Okay, there were two famous doctors from Lund University, and one of them is sitting there, Michael Kalbeck, and he's still alive, he's still my friend, and he's also a friend of his colleague, Mans Magnussen, And I call Mans the aggressor, and this is the victim. So Mans was trying to do the experiment with Michael about what happens if you have an acute bilateral loss. So he did a small injection with lidocaine, so to anesthetize the labyrinth. If you do that on one side, you get symptoms like vascular neuritis. So you get a sudden, acute vertigo, nausea, vomiting, etc. But here, first Mans injected it on the right side, and then on the left side. And then Michael was laying there, waiting and seeing what will happen. At a certain moment, he felt an urge to urinate. And he thought, after 1 hour. So he said, okay, I have to come out and go to the toilet. And then, as soon as he started to move, he started, hey, something changed. Something changed. He felt a little bit out of control. And then he started to think how I have to go up. And he behaves like an old man. It could be your grandfather, like that. Maybe he is a grandfather already. And he stands there like a robot, with a white gait. And he can stand, but he clearly felt out of control. And during this experiment, while he started to walk a little bit like a robot, while he was walking, he started to feel more and more nausea. But like a real Viking, he said, don't worry, I'm in control. I can do a Romberg. He's standing there. And then he started to feel this urge again. I think I really have to go to the toilet. But maybe not only to go to urinate, but also do all kind of other things. And I stop now the video here, and I continue with the rest. That's how he came back after having vomiting for a long time and feeling sick. And he said to me, Herman, I've never been so sick in my life before. Heavily sweating, and then he moves slowly over the ground, trying to prevent real movement and getting proprioceptive input, as you can see, climbing on the coach, and hoping and praying that everything will be soon over again. So it was a very nice experiment, approved by the Medical Ethics Committee in Sweden. We give a big applause. Michael, thank you very much. This is Michael. So heavily sweating. It took about 8 hours, I think, and it's reproducible. Huh? 7 hours. Okay. Okay, that's amazing, of course. What you learn from that, because there was no nystagmus and there was no vertigo, but there was a severe unsteadiness, ataxia, intolerance for voluntary head movement. He didn't want to move his head, and clear neurovegetative symptoms. So this is, I think, one of the best examples to show you that you can lose the function of two labyrinths without nystagmus and vertigo. That's amazing. But if you start to think about it, then the answer to that is relatively simple. In case of acute asymmetries, you have vertigo and nystagmus. So when there is an imbalance between the two inputs. But if there is a slow decay or an acute decay, but it's symmetrical, you don't have these classical symptoms. And that means, that implies, if you make the step to the clinic again, that vertigo is only one aspect of vascular dysfunction. Many people can have a loss of vascular function without this classical history. So you have to change that idea in taking the history and listening to your patients. So we have two aspects. We have vertigo, nausea, and nystagmus, and sensory dysfunction and function loss. This is a very crucial slide. Be aware of what is standing here. It means that the classical idea of managing vascular disorders was focusing on managing of vertigo and nausea. and didn't deal with the sensory deficit at all. If you make the extrapolation to hearing, it would be something like trying to treat tinnitus, but don't do anything about the hearing loss. And that's a very bad thing, because apparently we implicitly assume that the sensory dysfunction or function loss is not important, because we don't treat it. Is that true? Well, let's have a look at what is the major impact of losing vestibular function. And then we go back to why we have a vestibular system. And like I told you in the very beginning, we combine it together with all the other senses to do the job. And, well, there are much more things that are influenced by the vestibular system than spatial orientation, balance control, and image stabilization. It plays a role in the fast blood pressure regulation. It's already known since 1974, but it's not used in the practice. So if you come up very fast, the vestibular system detects that you come up and starts to co-regulate blood pressure in the brain. It's not only the baroreceptors that do that. The baroreceptors are relatively late. They start to regulate when the blood pressure is already going down. So the vestibular system is able to do it faster. So it adds speed to blood pressure control. And if you look at the circadian rhythm, there's a huge projection from the vestibular system to the suprachiasmatic nucleus. That is your biological clock, day and night rhythm. So together with visual input, it co-regulates your activity, movement, with your day and night rhythm. Makes sense. But okay, let us focus on the most important, clear impacts. So spatial orientation, for example. Well, if you look at a child, a normal child, you know, that tries to make a puzzle and put, as you can see, the head immediately on the right place, the trunk and the feet on the right place, has a clear notion, awareness of what is up and down, and you compare that with a child who has a bilateral loss, 26 months, it doesn't know, doesn't have this intuitive feeling what is up and down. It develops that later on, but it shows a very clear retardation in that development. So that is already related to a very important awareness, which is important in daily life, you can imagine. Now I need the sound. Now imagine you're sitting in the train and you expect that your train can leave any moment. Okay, you see that the train is moving. But you're not moving. So that is an example that you know in daily life. When you sit in the train and you look at the train beside you start to move and you get the idea that you start to move. When you're standing on for the traffic light, a big truck slowly moves on and you think, oh, I'm going backwards. You recognize that. So there's a very strong emphasis in the brain on recognizing motion with vision. And there's a continuous challenge between self-motion detection with the glasses of water in your head and with your visual system. Now, thanks to the fact that you have these glasses in your head, you are able to discriminate between self-motion and environmental motion, especially when there is a sudden movement. You know immediately, aha, I'm moving. So when the train moves a little bit too slowly up, you don't get the perception that this is self-motion or whatever. So in daily life, we use our labyrinths predominantly also for feeling the difference between self-motion and environmental motion. And that is why people with a vestibular loss, a substantial vestibular loss, have a reduced perception of self-motion. And they don't like to go in a busy environment where there's a lot of visual cues of motion because it troubles them. Am I moving myself or is it the environment? So this feeling that I showed to you in the train is a feeling that people without labyrinths have very often. And in the past, we were saying to Meniere patients who have lost vestibular function that they don't like to go to a supermarket anymore or a social environment. Say, oh, psychogenic. No, it might not be psychogenic because it is a consequence of losing vestibular function. Even it's so that the Münchener group showed very clearly, and also in Paris, Berthaud shows that there's a degeneration of head direction and head place cells, in the hippocampus. So there's a permanent loss in orientation capabilities in the brain when you lose labyrinthine function. So it's absolutely nonsense to say that the labyrinths do not contribute. They play an important role. Now, it's even more obvious when we talk about balance control, because then you can even see it with your own eyes that there's something going on with your patients. But you have to look in the right way. So, to summarize it very easy and to simplify it a little bit, if you look at what the labyrinth specifically does, it took me many, many years to understand that, and I hope that what I'm understanding now is correct, but we will see in the future. But to my interpretation, the vestibular system, first of all, is able to detect where is gravity, and that is a very intuitive perception. You're not busy with detecting gravity. The brain is constantly getting this information, knowing where is gravity. So if I suddenly lose my orientation, my posture, then my brain knows how to adjust my posture because there is gravity. So you don't need to think about that. And that works in any, even if I have no contact with the floor, or if I have a very soft floor that doesn't give me a lot of information. It's an absolute detector of gravity. And then it controls the extensor muscles, gives a certain posture and stiffness so that I can stand without any challenge. Okay, now what is the most important specific contribution of labyrinths to posture and gait? There are many structures engaged with, posture and gait, of course. But the specific contribution is that the labyrinth allows fast corrections and this intuitive detection of gravity. And they are able to do that fast. So they add, again, speed. So you can walk without labyrinths, and therefore many people think you don't have any burden from losing labyrinths, because you still can walk. You still can walk, and you can stand. But when you are in a condition where you need fast corrections, so on foam rubber, where you need to correct much faster, you will have a problem. Or when you walk like that, and there is suddenly a step that you don't see, then you will fall. So you have an increased chance of falling because you're lacking the fast corrections. And that's why these people are anticipating with walking, using their vision. So they look ahead, and they're very careful. They put their feet already a little bit wider, so that they have more stability, or they search for contact with the wall, or like older people do, take the rest near the stairs so that they can have a support. And that if they fall, they can correct themselves. So it is anticipation that needs now to replace, and constant attention that needs to replace the automatic posture control that is there thanks to the labyrinths. So again, the labyrinths add speed to balance control. Look at a child, about 1 year old. Walks pretty okay. That's relatively fast for a child. And here you can see a child, 26-month-old, without labyrinths. She tried, or he tries, to come out of the chair, knows that he will be out of balance, and needs to search very fast support or something like that. So he walks from one support to another support. So there's a clear retardation in the motor development in children when they have no labyrinths. They pick it up later, so they manage quite well at the longer term. No issue, they can do that. but it will always be a little bit more clumsy. And they will have more problems than normal children and be at risk to fall. Here you can see a child that lost Labyrinth 1 year after gentamicin intoxication, intensive physiotherapy and training, but you can still see that he walks like a drunken sailor. Yeah? So again, you know, time solves many problems to some extent. Children learn to cope with it, and this is a patient with a bilateral loss 5 months after gentamicin intoxication, intensive physiotherapy, and still walking like a drunken sailor. And that is precisely what people say. They say, when I wake up in the morning, come out of my house, my neighbors will say to me, oh, it's a little bit early to drink, isn't it? It's not a very pleasant remark from your neighbors if you see that when you have nothing that you have been drinking or whatever. And here's my oldest patient with gentamicin intoxication. She had a cystic fibrosis, and she had all kind of medications, corticosteroids, etc., and she lost labyrinthine function. And she has been training, you know, all the time. She was very motivated because her hobby was to hike with her husband, and they were hiking through the hills and forest, and she wanted to do that. So this is the best you can get. But still, you know, from time to time, you have this correction that is needed. Okay. So there's a reduced ability for fast balance control, correction, and there's a constant need for visual anticipation and attention. And people are generally very afraid to fall. Last but not least, image stabilization. Of course, a key figure now, key issue in our masterclass. Image stabilization. Well, it's very clear. If you look at this slide and you shake your head, you can still read the letters. And that is because the labyrinths, via the vestibular nuclei and the oculomotor nuclei, within 8 milliseconds are able to generate an eye movement that is opposite to your head movement. So when I move my head to the right, my eyes move to the left. When I move my head down, my eyes move up. So they are a perfect image stabilizer. They are in competition to some extent with vision. If you look at the smooth pursuit, when you move slowly, you can manage. But when I do it like this, you're not able to follow it anymore. And that is because the cortical pathway is much slower, 75 milliseconds. This has a very clear clinical impact. It means that there is no way that this reflex, this following smooth pursuit, optokinetics, can replace the vestibular function. It's not possible. There are all kinds of mechanisms that you can try to use, but this is not possible. So if you lose labyrinthine function, you have a problem. Okay. So, and that is the basis, in fact, of the head impulse test, where you make a fast movement, for example, horizontal, and you look at the eyes and see if there is image stabilization. We come back to that later in detail. And you can do that, of course, in 3 dimensions. So you can do it for the horizontal plane, but you can also rotate, as here, around the left anterior and right posterior canal. And you can do it in the other way direction. So that is basically the test that is directly related to image stabilization. And if you lose a labyrinth, this is a completely centrally compensated patient, and you make a movement towards the healthy side, as you can see here, there is reproducible, no problem. But when she moves to the bad side, you can see this small correction saccade that you are all aware of. And that is also reproducible, as long as you do it unpredictable. So it means that there is a loss of gaze stabilization towards the bad side, and that is clearly showing that the labyrinth, other labyrinth, is not able to take over that function. It's not possible. Of course, the brain starts to do many tricks to overcome the problem. Think about the overt saccades, the covert saccades, and things like that. Come back to that all later. And people try to avoid fast head movements. So all kinds of tricks. But fundamentally, the sensor is destroyed. So now the brain has to do it with one sensor and try to make the best of that. And some people can do it better than other people. That also makes sense, like with hearing loss. So in case of a bilateral loss, look at that, then of course, when you make a movement to one side, there is no VOR. And when you move to the other side, there is no VOR either. And there she tries to move her head also together with her eyes to compensate for the lack of the image stabilization. And that is a three-dimensional picture. You can see that in children, pretty normal, abnormal. You can see it in babies. You can repeat it. Look at my nose, Raymond says. Look at my nose, please. Here is my nose. Yes, thank you. Normal, abnormal. So, okay, so image stabilization, and we will go into that much more in detail. A consequence of that is, of course, that you have a lack of image stabilization, and when you walk to the doctor, to the ophthalmologist, you are saying, I have a problem with vision. And he's trying to find the door of the ophthalmologist. And the ophthalmologist put him on the chair and measure visual acuity. And he says, everything is fine, you're okay. Patient goes back to his partner and says, they can't find it. But while he's walking home, he already experienced the same problem. So what is wrong here? Wrong doctor, like was introduced. Wrong doctor. He had to go to the ENT or the neurologist because this is a loss of dynamic visual acuity and not a problem with the static vision. So you can measure that. Now, oscillopsia, perception of, this movement, dynamic visual acuity are not very simply correlated. It is very complicated. And that is because most likely the brain has all kinds of tricks to overcome these issues. Give you another example. You know these patients with a congenital nystagmus. And you see them in front of you and you think by yourself, how is it possible that they can see? But sometimes they have a visual acuity that is 0.9 or something like that, close to normal. And that is because the brain, because it's congenital from the beginning on, starts to develop in a different way and starts to be able to analyze moving images much better than in our brain. So they use a completely other strategy. No image stabilization, but analysis of moving images. And they're pretty good with that. And maybe this plays a role also in all kinds of compensation processes, try to deal with the lack of image stabilization. Okay, but if you measure the dynamic visual acuity, so the people are, for example, first standing still and you measure the visual acuity, and then you start to walk, so first static, and then you start to walk and you measure the visual acuity at different speeds. And you start to calculate how much do you lose. Okay, for normal people, the open circles at 2, 4, and 6 kilometers per hour, there is hardly any decrease of visual acuity. But for people with a bilateral loss, severe bilateral loss, definition is something for discussion, you can see that there is a substantial loss already at 2 kilometers per hour. So they only can see sharp when they're standing still. And when they walk on the street, they have a problem in recognizing faces and reading panels or things like that. They don't like to go shopping anymore. It's like looking through a camera, that you look through a camera and try to do the shopping or something like that. It's terrible. So don't say to these patients, everything is fine again. Because it's not fine, and they are the only people that see it, they feel it. Okay, is it uncommon? A huge study with more than 4,000 people. They investigated the dynamic visual acuity, and you see here the loss of dynamic visual acuity in people not complaining about visual acuity. So these were the so-called healthy population. Like presbyacusis is quite common, so these people have a loss of hearing normal for the age, which doesn't mean that it's okay. And that is here the same. They have a loss of dynamic visual acuity. It's not normal for the function of the labyrinth. They have a loss, but they accept it as a part of getting older. And there is, of course, a huge variation of people that really have problems and go to the doctor and say, I have a visual problem. So it's not uncommon, and it's showing that there is a clear aging effect of the vascular system. Like with hearing, there is a decrease of function with age. And that is associated with complaints about vision, complaints about instability, a fear to fall and falls. So, a permanent impact of the loss of the vascular sense for balance, vision, and spatial orientation, a loss of speed, a poor dynamic vision, fear to fall and falls. A loss of automatization, as you can see, and here you can see anticipation, attention, constantly requires, to prevent the falls. Anxiety, avoidance behavior, and presbyovasculopathy is a common feature. And the key factor is, of course, how can you try to assess this in your history? And how can you diagnose that with all kinds of simple and more complex tools? Meniere disease, when the attacks are over, it doesn't mean that everything is fine again. No, they have the tinnitus, they have the hearing loss, and they often still have the problems with the vascular system. And that holds for many of the diseases where we used to say, after the, everything is fine again. Okay. So, vertigo occurs only in case of asymmetries. Many patients do not report vertigo at all, but report problems with dynamic vision, fear to falls, and fatigue. And of course, these are not so specific complaints. There are many other diseases that have the same issue. Vasculopathy, two aspects, not only for the diagnosis, but also for the treatment. Now, what could we do? We could do, first of all, try to prevent things. Counseling, very crucial in the treatment, to explain that there is an impact when you lose labyrinths, and that you maybe cannot help that, but at least that they understand it, and they are recognized as people who have a complaint and a problem. Try to optimize compensation as much as possible and all these optimize sensory substitution. And then causal versus symptomatic treatment. Of course, you have the treatment of the vertigo and the nausea, where every focus was on until now. But we also have to look at restorage of functionality. Like you see the development of the vascular implant and things like that move in that direction. So, this is what I mentioned before. Now, to end up, some things that you will need to understand the next lectures, some major things about the vascular pathway. So, of course, the superior nerve sends the information from the canals, horizontal anterior canal, the utriculus, and the inferior nerve, that of the posterior canal and the sulcus, although there is a mixture of fibers. And 5% of the fibers are efferent fibers. So that is important. Apparently, the central vascular system is able to control or to influence the peripheral sensitivity. Okay, this is the most direct VOR that we know, via the vascular nuclei, the oculomotor nuclei, to stabilize, the gaze. And the vascular ocular reflex is, as you all know, when you move your head to the right, you get a stimulation of the canals, both of them, but with a dominance, of course, when you move to the right labyrinth, and via the medial vascular nucleus and the oculomotor nuclei, you can see that there's a direct reaction of the eye movements. These are things you can find in all textbooks, and you see that there is a fast component to the right, so the nystagmus that we all recognize with a slow phase and a fast phase, whereas the fast phase indicates the direction and the slow phase indicates the amount of response, the gain, the sensitivity of the system. Now, apart from that, that is the simple scheme, we have integrators, the gaze holders. And these plays an important role when we investigate eye movement and eye position control. So we have a part in the medulla with the medial vestibular nucleus and the nucleus praepostis hypoglossy. And for the vertical and torsional eye movement, we have also gaze holders in the interstitial nucleus of Cajal. So to show it more, to visualize it better, if you make a movement with your head, then during the movement, you activate the labyrinth and you get a direct signal leading to an eye movement. But after the movement, there is no stimulus of the labyrinth anymore. So if you would not do anything, the eyes would move automatically back to the neutral position. To prevent that, we have this memory that stores the activation during the movement for about 100 milliseconds. They keep that information there, so after the movement, you still can hold your eye in that direction. So, when I visualize it, when I make a movement of my head to the left, during the movement, my eyes are stimulated via the labyrinth to make this movement to the right. Now the memory is filled, it holds my eyes in that direction, and that allows my visual system to take over and to fixate the target. So you need that memory to allow the visual system to take over. Otherwise, there would be a saccade in between. And that holds for the horizontal and also for the vertical. The interstitial nucleus for Cajal and the nucleus praepostis hypoglossy. These are the gaze holder systems together with structures in the cerebellum. If you have a constant movement, rotation, for example, you see that the cupola is going down. It goes back to the neutral position by the elasticity of the cupola. So that would predict that within 20 seconds, or with a time constant of 6 seconds, 20 seconds, you would not feel any rotation. So if I make a rotation like this, I rotate, and I stop, then I would still feel for 20 seconds the rotation. But it appears to be that it is not 20 seconds, but it is 60 seconds. Yes, after 20 seconds, the cupola is back. But during this stimulation, again, the memory is filled. Like with the gaze evoked, nystagmus like with the eye movements. So when you start to rotate and move, there's not only nystagmus and perception of motion because of this pathway, but it's also stored here in the brain. And this is the velocity storage and makes the responses much longer. And we will see that when we do all kinds of tests, like the head shake test, where you start to stimulate the two things and you can see the asymmetry in the systems. Okay? And then a very important thing is that we have visual feedback via the parieto-temporal visual areas, the inferior olive and the flocculus to the cerebellum, to control the strength of the reflexes and also to suppress vestibular reactions, fixation, suppression. So the vestibular system and the cerebellum. Here the cerebellum, the adaptive control system of the vestibular system. The VOR in the dark is therefore very variable. If you have no feedback, the system doesn't know what to do. So that gives a huge variability in the caloric test where there's nothing to see. Because if you see something, you have a suppression. And when there is open eyes in the dark, there is no suppression, but the brain doesn't know what kind of eye movement should be generated. And in fact, in the dark, you don't need to generate any eye movement because there's nothing to see. So that makes it very variable, the responses. Very difficult challenge, and that is something that is overcome with the head impulse test, where you look at a target and you are asked to fixate the target. So then the brain knows what it should do. So that gives a huge variability in many of the tests, the classical tests as we performed it in the past. And then we have the head stabilization, as you can see here. So this is one of the best examples, how head stabilization is organized in birds. And basically you have the same, although you don't know. But when you're walking, you're running, you keep your head quite stable in space, with only a limitation of about 3 to 4 degrees in rotation. So the first stabilization is head stabilization, and then, they have on top of that the image stabilization that allows you to stabilize the image in space. So that is the vestibular colic and the cervical colic reflexes. And then we need the labyrinths for fast corrections when something unexpected happens. So after talking for hours, there goes Fidel Castro. So a nice example that if you do something that you're not paying attention, like I did a moment ago, you are at risk to fall, especially when you get older. So, and last but not least, perception. So there is a direct projection via the thalamus to the cortex. And thanks to many researchers, especially also the people from München, we know now that the parietrovascular cortex is one of the most important areas in the brain where the central processing, the cortical processing of perception of motion, orientation is done. So, that was the introductory lecture, so to bring you up to date on many of the things you already knew, but I put a connection with the clinical things that you be aware of, that it's not only vertigo, for example, and the challenge now is how can you use this information as a background to talk with the patient, to find out whether somewhere in his system something goes wrong. That is the history. And the second thing is, of course, how we can examine whether there are deficits in these patients and to understand the complaints.